Hi, good afternoon, everyone. Thank you for joining Jeff Foundation's community webinar series. My name is Danielle Edwards. I'm the Director of Community Engagement. We're going to wait here a few minutes or two just as we get some of our attendees to join on. So bear with us. We've got some great speakers with us today.
Some of us have people in our family who bled and died.
They were talking about President Biden.
All right. All right, guys, we got a bunch of people already getting on here so we can start things up. Again, everyone, thank you so much for joining us today. My name is Danielle Edwards. I'm the Director of Communication at Jet Foundation. As some of you already know, our webinar series will help ensure the Duchenne community is better prepared this year on just relevant.
No audio.
About steroid management and emergency situations. We will be taking drop any of your questions in the box below, and we will start the webinar. With that being said, Brian, I'll pass it off to you, and kind of for the speakers, just be, we're making sure we're mute when we're not speaking. So, Brian, I'll let you start. Thanks, everybody.
Well, hi, everybody. My name is Brian Nickloff, and first of all, I want to thank Jet Foundation, Danielle, and her associates. Dr. Smith, thank you for your time, and Kathy Kinnett, my dear friend from Parent Project, who has spearheaded PJ's protocol along with just everything that everyone wants to know about Duchenne muscular dystrophy. She's a wonderful individual in a lot of ways. I talked with Danielle, introduced myself with Danielle a few months ago, and we never really had any relationship at all with Jet. I've had it with Muscular Dystrophy Association for 30-some years, Parent Project, which is absolutely fabulous. I can't say enough words about that. And I don't want to take too much time because Kathy and Dr. Smith has the most important information, but I'm just sharing a little bit of information about what I feel very close to, and hopefully many of you will too, and that's PJ's protocol. PJ was our son who passed away in 2013. He was at the age of 31. He broke basically every bone in his right leg from the ankle up to the femoral neck over the years. He was on prednisone for 20 years, 20 plus years, 50 milligrams a day. So it basically made his bones brittle. He was obese, etc. But he didn't get in a wheelchair till the age of 17. He was very good, very active, had his own van, went to college, dated, etc. So he lived a good life. Unfortunately, we had a thing that turned bad, turned fatal. It was November 20th. We were at a residence in Florida, and we like to go swimming. Water buoyancy, by the way, is the numero uno for physical therapy. And we're in the water at least 2 days a week, year round, whether it's here in Indianapolis or whether it's in Florida or wherever. And we have another son, Justin, who just turned 34 last Saturday. Justin is still walking. He's Duchenne. He's missing exons 45 through 56. He weighs 100 pounds. He's 4'8". PJ was 4'8" and weighed about 160 pounds. So the prednisone did not help on that. Justin's never been on prednisone, only been on deflazacort. I think there's a difference with that. Anyway, PJ, I picked him up from the bed. We were going to go swimming, and we kind of missed the wheelchair, and he fell on his rear. And he said, "Dad, I think I broke my hip." And he knows when he's breaking his hip. He's done it before. So naturally, the cold towels and that, he didn't feel good. So we called 911. Before 911 came, I tried to pick him up, and he slipped on me a little bit, and his humerus shattered in half. So now it's not good. And so then we went to Tampa Hospital, and they looked at him, and he had a long bone fracture, no doubt, and so forth. So we ended up taking a flight home the next day. Remember that, because I think that's part of this with fat embolism syndrome. He had surgery up here and did very well. Both bones fractured were repaired. Was not a problem at all. That was on a Thursday. Friday, he was a little discombobulated to a degree, and they weren't sure what it was. They thought maybe it was pneumonia. They thought maybe it was a fluid on the lungs, what they call that, ARP, or distress syndrome, or rapid distress, I forgot now. Anyway, to make a long story short, that was on a Saturday, and he passed away on a Tuesday. Basically, we put, they were trying all different types of blood pressure medicines and so forth. Well, he passed away, and when we came home that day, the next day, we were looking at his drugs, and PJ was on deflazacort, which is not an FDA-approved drug, but the drugs were given to the nurse specialists and the physicians at the hospital. They were not administered to PJ. So that brings in steroid deficiency, adrenal crisis, all those things that contribute to his demise and that stuff. So we made a negative into a positive. I told the hospital, I met with the insurance risk people and then with the president of the hospital and so forth. And I said, we need to turn this into a positive so nobody else has a situation like this in the future. And that being a win-win-win. They need to have the educated physicians, nurses, et cetera, medical professional on staff that are aware of complications with chronic steroid users. That's kind of what it amounts to. Kathy will demonstrate that. And I want that to be a part of the EHR. It's in the electronic records with all of this hospital's locations, which is 20 currently. They were just merged with a larger company, so we're looking at many more hospitals in the future. It's difficult to get that accomplished. To go on with this, though, and that was the PJ's protocol comes up whenever someone is registered at a hospital. I think I'm correct in this clinical care, and if they're a chronic steroid user, it'll come up and it gives the comparison of dosage with prednisone versus deflazacort, et cetera, and that's what a protocol is. Basically, it's a list of rules to follow, to be educated on, and to follow. And it's when extremely I can't explain what it's done to it's really the wind beneath our wings, and continue to be. But I get letters, emails, calls, texts, etc., from various people throughout the world. I've got a box of it, and I continue to get them. I've shared some with Kathy. We've had the situation where somebody's been in the hospital and weren't quite sure what to do, and either were the medical professionals, and KK was contacted and got things handled. So you turned a negative into a positive there too. Here's just one little note here. This says provided the hospital staff. It says provided the hospital staff with PJ's protocol for my son today. Thank you. That's just one of hundreds that I've received. Since March 2nd of 2015. These medical cards that were produced, and with I think Duchenne or Parent Project made these up. These are emergency wallet medical cards, hanger size for wheelchairs and so forth. We get these 5,000 at a time. They're based out of Parent Project, but there's no cost to you. And I think Foundation was just given about 500 of those for your seminars, your webinars, for conferences, etc., and naturally for the people, the parents, the biggest advocates in this this family disease, and that's what it is. It's a family disease. The biggest advocates are us, the family members. That's the ones who are going to educate the medical professionals at various locations. I made sure that our cardiologists, pulmonologists, endocrinologists, neurologists, etc., our team is all very, very educated on Duchenne. If they're not, they will be, and if they don't, then they're not our care provider. And that's worked out well. That's worked out well. I've sent one of them to a conference put on by Kathy and the PPMD regarding bone, and Justin's, you know, and they follow through on that. They appreciate it, and they're educated more too. So I don't know what else to really say, except that I'm very honored that I got an opportunity to share this story. Being PJ's protocol, it's in several countries, several organizations, several languages, and it's not done. It's not done. I remember saying that when we were presented with this at the hospital that morning with Pat Furlong and Dr. Norris and Kathy Kinnett and our physicians, and I said, someday, I said, this will be from Bakerfield to Boston and from Maine to New Mexico and so forth. And that was just the beginning. And so I'll be on this till the day I can't. And by offering this through Jet Foundation, which is a great organization, and that's what we need as parents. We need you know, support groups, knowledgeable operations that care about us. It's they're special people, each one of you. And I'm just honored that I had a chance to actually show this. PJ's protocol website, the Facebook page is, well, I think we got 1,600 members right now, and they're from all over. A lot of parents, a lot of organizations, and a lot of sharing. They share the good, the bad, the ugly. You know, I tell people now, Justin's 31 or 34. We were on the first trial in 1987 with Dr. Mendel when he was at Ohio State for prednisone. They didn't have anything till, you know, now we're talking very valid treatments, cures around the corner, you know, so there's a lot of hope out there. There's light at the end of the tunnel, and the light's getting brighter and brighter and brighter. So for those of you that have associated family members that maybe are whether it's a newborn or whatever age now, there's a lot of hope. You got to stay positive. You got to stay positive. You got to communicate and share, and that's what gets you through. That's what gets you through. That's all I've really got. I really appreciate the opportunity.
Awesome. Thank you, Brian, for sharing that personal story. I think, you know, it's a great segue as to why we're hosting this webinar today. And, you know, kind of what all of us on the screen, you know, do for the Gen community is constantly looking for ways to give back and, you know, leaving the world better than we found it. And I think that's just a really great message and kind of why I love working within the Duchenne landscape. But with that being said, I'm going to pass that over now to Dr. Smith to do his presentation for everyone.
Okay, thank you, Danielle. Can you hear me?
Yes, sir.
All right, and I need to pull my talk up, and I don't see the share screen. There we go.
There we go.
Keeping me on my toes. All right,
all right, all yours now.
You can see my slides, so thank you. Brian, it's a pleasure to meet you virtually, and I just want to thank you so much for all of your advocacy and education around Duchenne and steroids in particular, and for sharing your story. I also want to thank Danielle and Jet Foundation for contacting me and asking me to be a part of this webinar. And it's great to see my friend Kathy Kinnett again after a long time of not seeing her. So anyway, it's a pleasure to be here. For those of you, and there are probably many of you who don't know me, I am a pediatric neurologist. I'm a neuromuscular specialist at Duke University in Durham, in North Carolina. I've been taking care of patients with Duchenne and other neuromuscular conditions, gosh, probably since 2004 when I was in residency. And we have a fairly large Duchenne clinical community of maybe about 140, 141 Duchenne patients of all ages. So the issues around steroids and steroid management and dealing with emergency situations obviously do come up. And you know, I suspect a lot of what you're going to see in my talk is going to be review, but that's good, that's okay. And maybe you'll learn, I don't know, maybe you'll learn something new, we'll see. If not from me, you'll certainly learn something new from Kathy. Just a really quick disclosure slide, because it is relevant to a couple of my final slides. I am involved in clinical trials. That's about half of what I do, clinical trials in Duchenne and other neuromuscular disorders. And when you're an investigator, a principal investigator on a clinical trial, some of your salary is paid by the sponsor of that trial. So there's a potential conflict of interest anytime you discuss things related to the disease under study, and in this case it's Duchenne. And so for today's talk, I am an investigator and have been involved in the Vamoralone program since its beginnings, at least in the clinic. And that's through a company called Vamoralone, and now a company called Santhera. So again, I'm going to have a few slides at the end, just letting you know a little bit about the Vamoralone program, but keep in mind that I am an investigator on that study. Real brief outline. You know, why do we prescribe steroids for Duchenne? So we're going to talk some about that. We're also going to talk about some of the negative aspects, obviously, of steroids, and Brian touched on quite a few of those already. It's interesting though, the Duchenne is the only muscular dystrophy that we use steroids for routinely, and you know, I don't know, there may be a potential benefit in some of the other muscular dystrophies. It hasn't really been looked at systematically. The reason we prescribe steroids in Duchenne is largely based on the work that Brian mentioned, that Dr. Mendel and the CIDD group started or carried out back in the late 80s and early 90s that showed a benefit. So we'll get into that in a little more detail, and then some of the management implications, and then Kathy's going to discuss emergency situations and resources, and then hopefully we'll have plenty of time for Q&A if I don't ramble too long. So some of you may be familiar with this diagram. This is from the initial version of the care consideration, the CDC Care Guidelines or care considerations for Duchenne, that was published, Kathy, I believe it was in 2008, and then updated in 2018-19. And it's really an attempt to just sort of in diagram fashion lay out all the aspects of comprehensive care for patients and with Duchenne and their families, with the patient and family, of course, at the center. And I put it in here only to, not to discuss all the other aspects, but to mention that, to show that corticosteroid management is a key component of this. It makes a whole lot of sense. There are a lot of questions around steroids and Duchenne, and I don't have all the answers. I'm going to try to, you know, so much of what I say might be opinion, but there has been some work over the years that's done a pretty good job, I think, at really confirming the benefits of steroids, whether that's prednisone or deflazacort, but also highlighting the negative aspects. So before talking about why prescribe steroids, how it's important, I think we'll just start with why would you not prescribe corticosteroids? And this just gets to the side effects that most of you are very familiar with. Probably the most common one we see is weight gain, and it can happen pretty quickly once the steroids are started. And weight gain, in my experience at least, is probably the most common reason to make a dosage adjustment or to switch formulations from prednisone to deflazacort or vice versa. And I've had it happen both ways. So weight gain is a real issue. The cushingoid appearance that you're probably familiar with, the sort of the full face and the truncal obesity sort of around the back and the shoulders and the trunk. And you know, it's not so much a safety issue, but it does become a real quality of life issue for many of our boys and many of the parents listening with teenage boys. They look different, and it's this cushingoid appearance, and it's due to the steroids. Pubertal delay, again, not necessarily a safety concern, but you can pretty much bank on delayed puberty, delayed or even blunted puberty, like not reaching full testosterone levels in adulthood. You know, these three so far are side effects that I think you just expect to see. We do have a small number of boys, young men who have not gained excessive weight, but the majority have. And that goes for both of the drugs. Growth stunting or short stature is another one that you can just expect with either steroid. There's debate about whether one's worse than the other. They both cause significant growth stunting and premature closure of the growth plates of the bones that once they close, the bones stop lengthening. So another negative side effect of steroids. Hirsutism, some of you may have noticed excessive hair growth, you know, on the back in particular, related to steroid therapy. Behavior is probably the other, besides weight gain, is the other negative side effect that triggers a dosage reduction or an alteration in the dosing regimen, which we'll talk about later, or switching to to the other alternative formulation. And as many of you know, in Duchenne behavior can often, in many of the boys, is often an underlying, even prior to steroids, the neurobehavioral, neurocognitive aspects of Duchenne, and many of the boys can be exacerbated once the steroids are started. To Brian's point, you know, osteopenia is going to happen. Osteopenia is a weakening of the bones, and then a propensity to fractures, whether that's an arm or a leg, or very commonly the vertebral bones. Vertebral compression fractures, extremely common after long-term corticosteroid exposure. Cataracts and glaucoma, we talk about these a lot, and we do see them periodically. Interestingly, they're rarely, cataracts at least, speaking of, is rarely severe enough to warrant a surgery, but in some cases it is. And glaucoma should be monitored for as well. So we certainly recommend that our patients be seen by an ophthalmologist every couple years, if not every year. And this will be a common theme, I think. And when they go to the ophthalmologist, I always tell my families, please tell the ophthalmologist why you're there, because if they see deflazacort on your medication list, they're going to blow right by it, or maybe they'll ask what that is. But they really need to know we're here because our son's on steroids, and we want to have him monitored for cataracts and glaucoma. So please don't be afraid to bring that up and mention that to the physician. Insulin resistance and even diabetes, type 2 diabetes, sometimes related to the weight gain, it can be an issue as well. So in our clinic, at least, many of our boys are at a particular age or a stage or time on steroids are followed by an endocrinologist as well in our clinic. And then here to Brian's point, and Kathy's going to get into this more, at the doses that are given in Duchenne, there will be, you have to assume there's some degree of adrenal insufficiency and a risk for adrenal crisis in times of physical stress or trauma where the body's really stressed. And so those need to be recognized and treated appropriately. I think, the choice of a medication, just like any big decision in life, whether it's for us or one we're making on behalf of our kids, involves some type of risk benefit analysis. Are we willing? It's rare that there's something with great benefit and no risk, or very little risk. And I would put steroids in the category of modest benefit, but with really high, with significant risk over time. And so it's not an easy decision. What makes it even more difficult is there aren't a whole lot of alternatives out there, right? It's not like there's another alternative to prednisone or deflazacort that has maybe similar benefit but less risk, or who knows, greater benefit and similar risk. So everything we're talking about today really gets back to this and this risk benefit calculation. What's the efficacy, the convenience of the drug relative to the safety and tolerability of the drug? And it's not in my opinion, here's my opinion, compared to some of the other drugs we use in neurology for other conditions, it's not a very favorable risk-benefit analysis for the current version of steroids, what's available. But it's the best we have right now. So hence the strong recommendation for initiating steroids in Duchenne and continuing them. So the next few slides are going to really sort of dig into a little bit more about why, what are the long-term benefits? What do we know about the long-term benefits? And this is a nice chart from a 2013 publication that really just sums up some of the basics of the natural history of Duchenne since the 60s and how certain things have changed or improved over time. And so the top arrow, and you can see these are in essentially 5-year increments. The top arrow is just showing the expected natural history prior to any type of treatment in essentially the 1960s. Loss of ambulation on average was 8-9 years old, so several years earlier than what we are used to today. And mean survival was at 10 to 15 years shorter than today. The loss of standing, the loss of motor milestones stayed relatively unchanged up until steroids were introduced. So in the 70s and 80s, there was more attention paid to scoliosis, and I think there was more sort of more aggressive intervention with correcting scoliosis and focusing on ventilation, non-invasive ventilation, and then subsequently possibly mechanical ventilation. And what that did was it expanded or prolonged the lifespan by around 10 years. But you'll notice these blue boxes, the loss of standing, loss of the motor function did not change at all, and that makes sense because these aren't treatments that would be expected to have much of an impact there. And then in today's world, sort of 1990s to now, with the introduction of steroids into essentially as standard of care, and also I think improvements in cardiac management, some of the medications and closer surveillance with on the cardiac side of the equation. We've seen an increase or an improvement in the motor milestones, or a delay to the loss of standing, of walking, and of upper extremity arm hand function. And we'll get into some of those details in a bit. And there's also been a modest extension in lifespan as well. But ambulation in Duchenne currently in steroid-treated patients is on average is going to be around loss of ambulation around 15 or so years of age, and that's a big improvement from 8 to 9 years of age few decades ago. I mentioned and Brian mentioned Dr. Mendel, and so this is one graph from their 1989 publication in the New England Journal of Medicine, and this is essentially the paper that the recommendation for steroids in Duchenne rests upon. This was a group called the Clinical Investigation in Duchenne Dystrophy, or CIDD group. And what this was a randomized controlled trial, meaning there was a placebo arm, and the physicians and others were blinded to who was on what. And this trial showed, at least short term, there were benefits on muscle strength, timed function tests, and pulmonary strength, or a measure of pulmonary strength called forced vital capacity. This is just one of the charts that was relevant to muscle strength, but the others followed suit and followed the same pattern. And what you can see is the bottom solid line is a group of patients whose natural history had been followed. So they were called a natural history comparator. Another group, this finely stippled dotted line, the next one up, are the boys in the study who received placebo, so they did not get steroids. And then the other two lines are one of two doses of prednisone, the familiar 0.75 milligrams per kilogram per day, and then double that dose. And you can see a clear separation there in terms of muscle strength. Again, remember, this was only out 6 months. All right, and we've learned a whole lot more since then. But there was what looked to be a clear separation between the steroid treated and the placebo treated patients in the study. And importantly as well, there did not seem to be any additional benefit to more steroids. So the double dose, or the 1.5 milligram per kilogram per day dose, essentially just caused more side effects. So the 0.75 dose is what was chosen. And we know something, I don't have it in here, but about lower doses, 0.5 or 0.3, and I think the consensus would be that they do those lower doses are more beneficial than placebo, or not getting anything, but you do lose some of the efficacy as well as some of the bad side effects. More more up to date, I guess, would be the data from this large natural history study that Craig McDonald and the Synergy group published in 2018. And Synergy stands for the Cooperative International Neuromuscular Research Group, and they've done a lot of work in natural history and in Duchenne, also in Becker, and have also, I think, been instrumental in sort of validating some of the measures that we use in our clinical trials. And this study, at least in the publication, the data that were published, this was from 440 boys with a 10-year follow-up. So 10 years, not 6 months, but followed over 10 years. And what they found was that the patients who were treated with glucocorticoids, with steroids, with prednisone or deflazacort, had an increased median age at loss of several of the what are called the loss of mobility milestones. Mobility was prolonged by up to 4 years in the glucocorticoid treated boys. And upper limb, very importantly, upper limb milestones, upper limb function benefited as well. Overall survival, there was a modest impact on overall survival. In this trial, during the duration of the trial, 39 of the boys and young men passed, and about twice as many of those were in the untreated, or the less than 1 month total steroid use. So there seemed to be a potential benefit in overall survival related to steroid treatment. And importantly, age at loss of ambulation. Ambulation was extended by a little over 3 years with steroid treatment, and so we've known that for quite some time. But it was good to see consistent results in this large study. And then finally, and I'll touch on this a little bit more, but the question always comes up about which one is, quote, better, deflazacort or prednisone. And in this publication, the milestone transitions or the progression of disease tended to be more delayed in the deflazacort treated population over the prednisone treated patients. But Dr. McDonald the paper is very careful to say that there are numerous reasons that this study was not designed to show a benefit of one over the other. There's a large trial going on right now to try to figure that out, answer that question, called the 4DMD trial, looking at prednisone versus deflazacort. In terms of motor function, and here you can see these two panels. The upper panel is age at loss of ambulation milestones, and B, age at loss of upper limb functional milestones. And this is from that Synergy paper. The blue dots are the untreated boys, and the red dots are the steroid treated, again, prednisone or deflazacort lumped together. And you can see on the vertical axis or the y-axis what's being tracked. So, how long did it take to reach a time point where it now took 5 seconds to stand up from lying down on your back, and then 10 seconds, and then ultimately loss of ability to stand up, loss of climbing ability, and then ultimately loss of ambulation, and similar type of progression with the arms, with something called the Brooks score, which is just a measure of arm function. And so what you can see is that the red dots are farther to the right, all right? So and that just signifies that those patients reached those milestones, and milestones in a negative way here, right? Disease progression milestones at a later date, at an older age. Okay. Also from the study, we've known and felt for some time that steroids have a modest but a positive effect on pulmonary function or lung function, and that's what these are two of the same data sets, just shown a little bit differently. I think the one on the left is a little bit easier to look at, but you could see the purple filled in circles are steroid treated boys and young men, and the empty circles are the untreated. And so age is on the x-axis, and then the vertical axis is pulmonary strength. And so the higher up you are on that y-axis, the stronger your breathing capacity is. And what you can see is that the time it took to reach this number of 80, that's what these dotted lines are, which is sort of an agreed upon number for this is the beginning of the decline in pulmonary function, was extended or delayed by about 2 years with steroid use. It's interesting that the rate I don't want to get into the weeds, but the rate of decline is fairly similar whether you're on steroids or not, at least in this data set, and I think this has been seen other places. So it may be that steroids slow or delay the onset of the beginning of the decline, but don't necessarily impact the rate of the decline once it starts. And then that would beg the question, well, should we just do steroids until we begin to see this decline and then come off of it? But the prior slide I showed you shows you that there's an ongoing benefit in terms of motor function. All right, I hope that made sense. Cardiac function is a little more difficult. I think in my mind, it's still debated quite a bit. Some folks say there's a definite benefit, others say we don't know. The chart on this is from a paper that came out in 2013 that's often cited, and just look at the graph on the right, and the solid black line are steroid treated patients, and the dotted line are those that are not treated. And where they separate out, that separation is portraying who's developing cardiomyopathy. So as the line goes down, that means more patients are developing cardiomyopathy, or weakening of the pumping of the heart. And you could see a clear decline in this study in the non-steroid treated group. So, and there are other papers out there that show similar findings. This one's really interesting to me, and others, and I don't think I really appreciated it until several years ago when one of the orthopedic surgeons I work closely with, who's I'll just say he's older than I am, and has known Duchenne patients for several decades. And he asked me one day, he says, "Where are the Duchenne scoliosis patients? I'm not seeing very many at all." And I think it's related to this. I think this is almost entirely a steroid phenomenon for reasons I don't understand, and nobody can explain it to me. When you think about how bad steroids are for the bones, especially the vertebral column, and the vertebral compression fractures, you'd think that scoliosis would be worse potentially, certainly not better. But this was a really well done study that was published in 2013. It's Canadian, and looked at 54 boys ages 7 to 10, and with a 15-year follow-up. And they were all on deflazacort. It was Canada, and so they were all on deflazacort, I believe at 0.9 milligrams per kilogram per day. I didn't get into the weeds to see how many of them in adulthood, what their maximum dose was, but regardless, they were on a stable or a steady deflazacort regimen. 24 of them were not. 24 of the 54 were not on corticosteroids. So you can see the treatment arm and the non or the no treatment arm, and you see the separation again here. We've got time and years of follow-up on the y-axis, on the x-axis, and then the survival rate on the y-axis. Survival here is just the definition would be did you develop severe scoliosis, and that was defined as at least a 20-degree curve, which for this group at that time was when surgery was essentially recommended. And long story short, in the treatment group, only about 20%, so 2 out of 10, developed significant scoliosis. In the untreated group, it was over 90% by the time of the 15-year follow-up. So that is my answer to my friend in orthopedic surgery as to where's the scoliosis. So that's been a definite benefit of steroid therapy. Even though I can't explain it, we'll take it, and because that's a win. I also believe that lack of scoliosis or a straight spine has a positive impact on pulmonary function. Okay. Another question that comes up is when to start. I don't have a good answer to this. We do have our care considerations that were here. They were updated in 2018. There's a lot of debate about this. I don't think there would be as much debate if we weren't so worried about the side effects. We'd probably start earlier. In my opinion, the general consensus, and it's in line with the care considerations, is to really begin to seriously consider starting steroids around the age of 4 to 5. Another important, and now there are, I put an asterisk by the 4 years because Emflaza, so the American version of deflazacort, in their FDA approval or their FDA label now, they have an indication down to 2 years of age. I have not started anyone at 2 years of age on steroids. If a family came to me and really wanted to, we would have a long talk about it, and I'm sure I would do it. But generally, when we really delve into the side effects, and I think the lack of really good data in terms of efficacy in the younger age group, it's hard to, that risk benefit analysis gets even harder because there's a lot of I don't know in that calculation. It may end up, it would make sense, right? If we know that the muscle in a 1-year-old or a 2-year-old with Duchenne is not normal, is inflamed, and should respond in much the same way as a 4 or 5 or 7-year-old's muscle would respond to steroid therapy. So it may very well be beneficial. I don't think it's been looked at enough for me to make a strong recommendation. So, and Kathy can chime in later during her portion of the talk on that, but the care considerations essentially give us the 4 to 5 year age range. And then of course, make sure immunizations are up to date. And I just put that in. This is a typical immunization schedule out through 6 years. And the red box here is this age group, right? 4 to 6. And MMR and varicella are typically the booster shots for those are typically given at this time. And those are considered live vaccines. And we prefer to give those when someone's not on steroids and potentially somewhat immunosuppressed. Not potentially, they are immunosuppressed to some extent. And so we like to try to sneak the MMR and the varicella boosters in before starting steroids. To the question about prednisone versus deflazacort, and it's not really the point of my talk, but I just wanted to bring this up. This is again from that same Synergy natural history study, and there are a number of these charts looking at, this one looks at ambulation, but at all aspects of motor function. They can be, it's really a good paper to read if you guys have a little extra time. But what they found was that weight gain appeared similar between prednisone and deflazacort. Now but 440, but these patients were different ages, they had different doses, it was a real world sample. If you go from one MDA clinic to another, you're not going to find all the patients of the same age on the same doses of the same steroid. So it's very messy, which has made it very difficult to answer some of these questions. But in this large cohort, this large group of patients, it looked like weight gain was similar between the two drugs, and that deflazacort had potentially had more of a propensity to cause more severe Cushingoid features, more growth stunting, and more cataracts. I don't know about the Cushingoid. I think I would agree with the growth stunting and the cataract. Again, this is my opinion. And in my experience, the weight gain has been in favor, to some extent, in favor of deflazacort.
Hi, Jess.
It's sorry, somebody is not on mute. And I have ADHD, so it's hard to but what you can see here, so another one of these plots of showing time on the or age on the x-axis or the horizontal axis, and then the percent of patients that were ambulatory. You can see in the red line is the untreated. I'm sorry, the red line is sorry. Oh my goodness, did I do that? The red line on the left panel, the red line, I don't want to misspeak, but the red line is untreated, and the give me just a second. Yes, so I'm just looking. The caption is over on the other one. So the red line on the left panel is untreated, and the black line is treated with steroids. And you can see this sort of, it's about a 3-year difference, right, to age of loss of ambulation from 10 to 13. And then on the right panel, the black line is prednisone, and the green line is deflazacort. And you can see the difference they picked up there and the prolongation of ambulation. And, in some ways similar to that pulmonary function plot, it looks like, at least on this plot, that the green line starts to decline later. And when it does begin declining, it declines at a similar maybe similar rate, but regardless, there were many more patients still ambulatory, able to walk at least 30 feet without help, to almost 3 years later in the deflazacort treated group. Okay. This is just a reminder, I almost took this out, but when we talk about management, it's really management of the side effects of the steroids or the potential risks of emergency situations, and hence this talk. I don't want to go through all of these, and I don't even know if you can read them, but most of them we've already talked about. But we steroids give our patients more problems, new disease, and we have to manage that, and that's managed on an individual basis. But we certainly follow aspects of steroid treatment regularly in clinic, including the growth stunting or the weight gain and the behavior, all the things we've talked about, and try to provide education and support and make medication changes if needed. So that brings me to sort of this alternative discussion on alternative dosing regimens. The CIDD, Dr. Mendel's trial was daily, once daily, prednisone. Over the years, different people have tried different dosing regimens, largely in an attempt to reduce the side effects, right? To make the risk a little bit less and without impacting the benefits. And I'll just tell you, it's a mess. I don't think there's a good answer yet for what alternative dosing strategy is, quote, the best. These are the three that you'll often hear about after the more standard daily dosing. There's an alternate day dosing, which is just what it says, every other day. There's a high dose weekend dosing regimen that's been looked at and is being looked at and even used. And then there's an intermittent dosing of 10 days on and 10 days off, or 10 days on, 20 days off. I think that one is more common in Europe. The high dose weekend is probably more common in the United States. I think there's pretty reasonable data to say that the alternate day regimen is really not beneficial. So in my clinic, I as a general rule offer and recommend daily dosing. We may switch to high dose weekend if side effects warrant that. The dilemma here is these are really high doses, right? Look, 5 milli. So if we're just talking about prednisone, the dose of prednisone typically is 0.75 milligrams per kilogram per day. So this is, my math ain't great, but that's 6 or 7 times that on a Friday and Saturday, or a Saturday Sunday, with nothing given during the week. So it actually ends up being more total steroid over the course of 7 days. But there's some data out there from Dr. Ann Conley and others that it may be better tolerated and have similar efficacy. The other benefit to something being better tolerated is that you don't have to reduce it. So if a steroid or a regimen like high dose weekend allows better tolerability, then you're able to maintain that higher and likely more effective dose because of the better side effect profile. Safety, Kathy's going to handle this, and Brian already introduced all of this. We're very grateful to have the PJ Nickloff steroid protocol, which gives guidance around missed doses, stress dosing during illness, trauma, signs of adrenal insufficiency crisis. These are tough. They are typically really non-specific and won't be on the doctor's radar unless they're thinking about it. To Brian's point too, just this is not a slam on the medical community, but just don't assume that the doctor or the resident or whoever healthcare provider you're talking to knows much about any of this. And beware of shift changes as well. This has happened to me multiple times in the ER where the resident or even the attending says, yes, we'll pass this on to the oncoming team and administer stress doses, and it didn't happen. So you've got to stay on it. The problem here is that, you know, all of us, we have adrenal glands and our adrenal that sit on top of the kidneys, and they make steroid for us, and we need a certain sort of steady dose or amount of steroids in our bodies for many of our bodily functions for things to work right. And if we don't have those steroids, we run into problems with things like blood pressure, blood glucose control, and a multitude of other things. So when you import your steroid in the form of prednisone or Emflaza, deflazacort, those adrenal glands, think of them like your steroid factory. In your son, I mean, they shut down. So and you rely on that imported steroid. If you abruptly stop the import of those drugs or that drug, your factory does not just light up and start running again. It doesn't work like that, right? There's a long period of time during which you are adrenally insufficient and at risk for adrenal crisis, particularly in times of significant physical stress, illness, trauma, fractures, as Brian mentioned. And you know, in those situations, not only do you need the normal amount, but you need more. And that's what our adrenal glands would typically do. They would generate stress doses. So that's all important to know. And I think the most important point to make here is communication, and don't be afraid to speak up to the doctor and just remind them that your child or that you are on chronic steroid therapy, you're adrenally insufficient, and likely need some extra steroid, depending on the situation. All right, I'm getting to the end here, I think. And this is where my conflict of interest starts to potentially come up. I hope I don't portray a conflict of interest. I think we would all agree. I think we would all agree that we hope for something better than deflazacort or Emflaza or prednisone. And better is kind of hard to define. Better comes on a spectrum. The best would be that we had a cure and could just make this mess go away and cure Duchenne. We don't have that. We're hopeful that someday we will. But better would also be maybe reducing the negative side effects and maintaining a similar efficacy of, let's say, of steroids. And so that's what the next few slides and what the Vamoralone program is about. It's a steroid, and the goal was and is to keep the improvements that we see with steroids, in terms of ambulation and arm function. I wouldn't say delay, I'd say prevention of scoliosis, but reduce the bad side, the weight gain, the osteopenia, the growth stunting, all the things we've talked about. And you know, and can that be done? And the term that's used in I guess in pharmacology here is a dissociative steroid, where you dissociate the good from the bad, and in favor of the good. And so the answer is, well, maybe we'll see. In my mind, it looks promising that Vamoralone might offer this to some degree. So this is a drug that is currently in clinical trials. It has been since 2016 or so. Very similar for those chemists out there. There's a diagram here of the chemical structure. But the short version is that because of a small change in the chemical structure, this steroid, and it is a steroid, is able to maintain or keep its anti-inflammatory activities, which we think is one of the large drivers in the benefit we see from deflazacort, prednisone, but then reduce some of the bad side effects. I'm showing this. This is a plot of a test called the time to stand rise time. So the amount of time it takes to stand up from lying on your back, and this is from the current study, which is called a phase 2B study. It's a placebo-controlled study that's going on, and I think it was 121 boys now got enrolled worldwide in this, and that study is looking at actually 2 doses of Vamoralone. This shows the high dose of 6, but 2 doses of Vamoralone versus placebo versus a standard dose of prednisone. And what you can see here is on the x-axis again, time, so weeks into the study. And these are, I forgot to mention, these are all boys who at time of entry into the study were 4, 5, or 6 years old and had never touched steroids, so they were steroid naive. So entry into the study, they're put on either placebo, Vamoralone, 1 of 2 doses, or prednisone for the first 6 months. After week 24, the placebo and prednisone treated boys can switch over to 1 of the 2 doses of Vamoralone, and so we're waiting on that data now. But so this is from the first half of the study, and what you can see is the gray line is placebo, and a dip here, a decrease, is an improvement. It takes less time to stand. The red line is prednisone, and the red line is Vamoralone, and the dotted or dashed line is prednisone. And the take-home message here is that that they seem to have similar efficacy, at least at these doses, and using the time to stand as a measure. There were multiple other, and are multiple other measures that are being used, and they show very similar things. Another thing that seems to be happening that was not unexpected, but it has been seen on the right, is from a study that started several years ago and is now the LTE. There stands for long-term extension. And then on the left is the study I was just discussing, with the solid red bar being the high-dose Vamoralone group and the black bar being prednisone. Here you're measuring growth, or linear growth, and essentially the Vamoralone treated patients appear to be maintaining normal growth velocity or growth trajectory. So they're growing, seem to be growing. We'll see, because they haven't finished growing, but they're growing along a normal growth curve in terms of height, and as expected, with prednisone or expect something similar to Flazacort. That's not the case. There is, it probably come up in the question, there's debate out there about isn't short stature potentially beneficial and protective in Duchenne, and I think some people would argue there may be a modest benefit. I'm not sure that there's a good answer to that. So I can't say yes or no. I do know that most of my patients would rather be able to maintain something more like a normal height or normal growth trajectory. It also helps to carry the weight that comes along with steroids, and that gets to this slide. Here again, solid red is Vamoralone high dose, and solid black is prednisone, and the point in this slide is that there really wasn't a difference when you look at the numbers between prednisone and high dose Vamoralone in terms of weight gain. So that's unfortunate, but it seems to be the case. So similar propensity to weight gain, but also, keep in mind that these boys are growing taller, so that weight is dispersed over a taller height. And when you meet these boys or see them, they do look different. They don't look like a typical, more typical prednisone or deflazacort treated patient. So this is all in the works, and I hope, we'll see. I keep your eyes open for potentially for other trials of Vamoralone in different age groups outside the 4, 5, 6 age group. I think there will probably be a younger age group, which makes sense, and then older ages. and there's a lot more information that we're waiting on that I haven't gone into, but it does look like this drug the bones tolerate it much better. It does cause adrenal suppression at these higher doses. So the PJ Nickloff steroid protocol is not going to be going anywhere anytime soon, but if Vamoralone is FDA approved. Last thing, because this just obviously keeps coming up, and I'll let Kathy chime in during her talk. This is anecdotal. I don't know that it's been systematically studied. This is from discussions with other physicians who see Duchenne patients and just the community. I'm not aware of any obvious increased incidence of severe COVID illness or infection for that matter, but severe COVID illness in Duchenne. This has come up and was a question because obviously many of the boys are treated with steroids, and the idea would be that, well, maybe they are immunosuppressed to some extent. Does that put them at a greater risk for infection and potentially severe illness? And thus far, as far as I know, the answer to that is no. We do recommend a COVID vaccine for boys who are 12 and older. The 12-year-olds can get the Pfizer vaccine. And then this is really recent, right? The idea of a third dose or a booster dose. And when you look at what the CDC sent out in terms of guidance on who should get this, there were multiple bullet points in different populations. And the last one, I think, was patients on high-dose steroids. So that gets to the question that always comes up: how do you define high dose? And there's not a good answer to that. And if there's not a good answer to it, I tend to, I guess, potentially err on the side of caution. The generally accepted definition of high dose is 1 milligram per kilogram per day, or 30 milligrams per day of prednisone for at least 3 months. So our older boys generally are on 30 or 36 of deflazacort, 30 milligrams a day of prednisone. That's at least where I sort of max out my dosing. So by this definition, they would fit that. AAP, the American Academy of Pediatrics, has guidelines that say you should be considered immunocompromised if you're on a 2 milligram per kilogram per day dose. And remember, we only do prednisone. We use lower than that in Duchenne, but there's a total dose of 20 milligrams per day for a child greater than 10 kilograms for at least 2 weeks. So all that being said, my recommendation, until I hear otherwise from Kathy or Jet Foundation or PPMD or the CDC, is to recommend a booster dose, the third dose. Okay, and that went on longer than I had anticipated. I'm sorry. Kathy, I hope you have enough time left for your portion of the talk, and I'm gonna go on mute and hand it over to you.
Thanks, Eddie, for that presentation. I'll pass this over now to you, Kathy. 1 second. There we go. Awesome. Again, everybody, please feel free to join, drop some questions if you have some. And then Kathy, I know you'll probably be quick with your presentation, but appreciate it. So thank you, guys.
Thanks, Eddie. It's nice to see your face as well. It's been too long since we've seen everybody. So I think we're all hoping this craziness was over, but not quite yet. So I'm going to, hopefully everything that I present today will be a review, but if it's not, then I hope that you'll take these suggestions and use these resources and find them and do everything with them that you can. So let's see. As Eddie said, emergencies never happen where you want them to happen. If you travel for care to a clinic or a center or a certified Duchenne care center that's far away from you, it's unlikely that your emergency is going to happen in that parking lot, unfortunately. So it usually is going to happen in a place where you are, and most likely in a place where people are not familiar with this diagnosis and not familiar with the care that your son or yourself requires. So sadly, you might be the expert in the room, and it's important to know what you need to know. Now, our job is to make sure that because you're going to be in crisis, that you don't have to memorize everything and that you have resources at your fingertips. So in order to provide those, we have developed a mobile app. And if you don't have this app on your phone, I would strongly encourage you to get this app on your phone. And I'm just looking at the app, and the categories in the app are the emergency care considerations, the checklist, important contact information, surgery and anesthesia, oxygen, risk for adrenal crisis, so the protocol, fat emboli syndrome, rhabdomyolysis, care for the flu, care for GI illness, medical IDs, and then information about you. So all of this will be available at your fingertips and available when you need it. Just make sure that you have this downloaded and you are ready to give the information to whoever needs it, wherever you are. The emergency checklists is something that we came up with so that you would have the information that you needed for the specific issue that you needed attended to in the emergency room. So if you're going to the emergency room for a breathing problem, you're going to need information that may be slightly different than if you're going into the hospital for surgery. So each one of these checklists is available both in the emergency app as well as, or the mobile app, as well as on the PPMD website. So again, I would take some time to familiarize yourself with what's on each of these so that you don't have to guess about what it is that you need when a crisis arises or when you're stressed because you need to go in for a surgery. So take some time to review these and download them in the app as well. Medical IDs are important, and we've worked with a company called Lawrence Hope in order to make medical IDs available to families living with Duchenne. Medical IDs don't have all the information on them because the information that's on the medical ID is really only for the first responder. So you want this information that on the medical ID that the emergency squad is going to need or the emergency room is going to need right away. So any first responder that comes to your house is going to need to know your name and your birthday, obviously, your medical condition. If there's more than one, make sure you list them. If it's Duchenne and asthma, they need to know about both of those. So make sure those are both on there. Medications that you're taking now, to include steroids, like Eddie mentioned, it's important to let the emergency staff know that you're taking steroids, what your allergies are, and then who to contact in case of an emergency. If somebody fell on the street, if somebody fell in the mall, you don't have anybody with you, they need to know who to call. The reason that we worked with Lawrence Hope is because most boys don't want to wear a bracelet, but they will wear a sports band. So Lawrence Hope had a variety of options that were available for children who maybe didn't want typical medical ID jewelry and made those available to us with a small discount if you ordered through the website. So you can take advantage of that or not, but I would definitely make sure that you or your child has a medical ID if you have Duchenne. Emergency wallet cards are not new. The updated version is available from PPMD. If you go to a certified Duchenne care center, they are also available through your coordinator or through your clinic. We've made them available in both English and Spanish, so you shouldn't have any problem getting all of the information that you need and to the emergency personnel. So again, if you need any, get them from your certified Duchenne care center. If for whatever reason you can't find them at that place, you can always order them from us. The information on the wallet card is an abbreviated version of what's in the mobile app. Did I go there? Oh, yep, sorry. Also available are wheelchair cards. So we have a wonderful coordinator named, oh my gosh, Alexis Hazlitt, sorry, she just escaped my mind, who developed this wheelchair card at Children's Mercy in Kansas and made it available for us as well. So on this emergency card or the emergency information, it's large, it's waterproof, and it's attached to your child or your wheelchair. We found that when emergencies happen with people who are non-ambulatory, the wheelchair is often the most consistent piece of equipment that's with them. So we wanted to make sure that this information was available on the wheelchair, or with the child, with the person, and on the wheelchair. So it's two-sided, one for families, one for medical personnel. It's also available in Spanish. The Spanish version is on the family side. So with Spanish for families, and then the English version is on the for healthcare providers. Again, it's for first responders and for initial information in the emergency room, and you can obtain those either through your coordinator at a certified GC Care Center or from the PPMD website as well. We do have a new resource that was just released, I think last summer, about the one for safe and unsafe medications and one for laboratory tests. We're working to put that on the mobile app. They're not quite there now, but the safe and unsafe medications covers all medications that may or may not be given in the emergency room, as well as many of the over-the-counter medications that parents and families have questions about. So please refer to that resource. You can download it and or print it, whatever is easiest for you. We also did a resource for laboratory tests. We found that many families get a lot of tests, but they don't really know why they're done or what normals are or what the results mean. So all of that's included on the lab sheet. And again, that's available for download on the PPMD website. Eddie talked a little bit about adrenal insufficiency. And so just as a quick review, if you're on daily steroids, your adrenal glands that normally release cortisol realize that that cortisol is coming from somewhere else, so they temporarily just sort of take a little nap. They take a nap regardless of whether or not there's an emergency or whether your body's under stress. And so your body is only going to get the dose that you get normally, regardless of what's happening in your body. And if you don't have enough cortisone in your body, you can have acute adrenal insufficiency, which can cause multi-organ failure and can be life-threatening. So if you've missed a dose of steroids for more than 24 hours, so you've missed one dose and you're going on the second day, you need to go to the emergency room because you're at risk for adrenal crisis, because your body does not have any other way to get cortisone, and your adrenal glands, as Eddie said, take a little while to wake up. So if it's been more than 24 hours, you can't get enough that dose in, then you need to go to the emergency room and substitute your cortisone by IV. And as a reminder, many people who aren't familiar with Duchenne don't realize that liver enzymes are normal in Duchenne. It's because your liver is processing muscle waste. It's not because there's liver failure. So please remember to tell them that high liver enzymes are normal in Duchenne and don't need any further investigation. So again, if your body's under stress, daily dosing of steroids may not be adequate to allow the body to cope with whatever stress it's under. And so your body needs a stress dose, which is just exactly what it sounds, a dose of steroids to help deal with whatever stress your body is in. On the PJ Nickloff steroid protocol, there is a description of what mild, moderate, and severe stress is in a little graph form. It identifies what illness, what stage of illness, what type of illness may be mild, moderate, severe, where types of surgery fit, and where pain fits. And then it gives an appropriate stress dose based on the level of stress that your body is under and based on your body mass. So again, the PJ Nickloff steroid protocol is incredibly important. It's important not to stop or miss doses of steroids. There's a conversion table on the protocol. Stress dosing is described and identified and specific on the protocol. Symptoms of adrenal crisis are included, as well as exams and tests to evaluate the adrenal function. And again, the PJ Nickloff steroid protocol is available both on the PPMD website and on the PPMD mobile app. I think that's it for me.
Awesome. Thank you, Kathy, so much for that presentation. I'll just bring it back to me as a presenter. Let's see. All right. With that being said, everybody, thank you, Brian, Eddie, and Kathy for sharing your presentations with us all. I will open the chat right now for questions to take. We already have a few coming through, which is great. So I guess we'll start, and I guess Eddie or Kathy, whoever you feel might be best to take the question, just kind of answer that way.
Okay.
Start with this one. Also, just so everyone knows attending the webinar right now, this is a recording and will be available on our website. I think what's really great about going virtual is we've gotten the opportunity now to connect with, so many others throughout the country, and this is really important information that you can bring back to your physician and share with the general community as well. With that, moving forward, I'll read off the first question. Let me see. Did any of your kids on steroids have a hunger issue, and how did you help them crave that hunger? My son is taking Immunizations and has the weight gain and is constantly hungry.
Yeah, that's appetite. Increased appetite is a big driver of that. There's also some water retention from the steroids, and then there are also boys who are just big eaters, and then that just is exacerbated by the steroids. So, that's a very I don't have an easy answer to that one. That's a very individualized answer. We have a dietitian in our clinic who can really do a sort of a deeper dive into what's actually going on, what's available in the house, it sounds cliche, but the healthy choice is having, okay, you're hungry, well, let's find you something that you like, but that's relatively healthy and not just a simple carb or something like that. So I think that's a very individualized thing, and it's just really, really tough. Whether you're on steroids or not, weight gain's difficult. No doubt, though, that a lot of the weight gain is driven by increased appetite. And if it's too much, we would switch. If they were on prednisone, we may switch over to Deflazacort or vice versa. I had a patient last week who had been on Deflazacort for several years, and had been on prednisone for several years. He's 15 now, and started seeing a new provider who switched him to Immunizations, and his appetite and his behavior worsened. This is from the parents, worsened dramatically, and he gained a lot of weight. Switched back to prednisone, and all that seemed to get better. It often goes in the other direction with those two drugs, but that's just why this is always has to be an individualized discussion about the patient and what their environment is at home, and school's a whole nother issue I won't get into with school lunches and what's available. What's called lunch. So, pizza for breakfast. So I don't know. I don't know that I answered your question very well, but I think that I would seek out a dietitian or a nutritionist through the clinic where you're followed, and maybe have a more in-depth discussion.
Mm-hmm. Awesome. And I think I just want to piggyback on that one. We did host a really great webinar with Perlita Haynes' brother, who's a GI out in Chicago, and he actually talked about kind of just a lot of water intake, fruits and vegetables, and things like that to be just conscious of. So if anyone's listening, a great another webinar to watch to just kind of help that piece. Based on the information that Dr. Smith shared, the general recommendation for dosing of prednisone is 0.75 kilograms correct. What is the recommended Immunizations equivalent?
It's a little bit more. Prednisone's a little more potent than Deflazacort. Kathy showed the correction there, sort of 5 to 6, but it's 0.9. So instead of 0.75 milligrams per kilogram per day for prednisone, the recommended dose of Deflazacort and Immunizations is 0.9 milligrams per kilogram per day. So a little bit of a higher dose.
Yeah, they have the comparison chart on the protocol also.
Right.
Of the Deflazacort versus steroids.
Okay. We've got another question. Hello, my son is from Poland. Sorry guys. Hello, I'm from Poland. My son is 13 and a half years old and he's still mobile. He takes 21 milligrams a day of Deflazacort. Main side effect is short structure, 135 centimeters. Should we think about growth hormone therapy?
Yeah, that's a tough question. There is this is hotly debated and has been for a long time, and I don't think the debate's going away. Kathy, you can agree or disagree. In our clinic, with our endocrinologist, it is something that is sometimes is discussed. I will tell you though that we don't end up prescribing a whole lot of growth hormone, and although there are some patients who are. So will it increase height? It can even in the face of steroids, it can increase height by a few centimeters. Does it? Some people have made an argument that growth hormone would help with muscle growth and strength. I don't know that that has been definitively shown. And then, growth hormone doesn't come without some potential risks. It's also extremely expensive and hard to get, at least in this country. I don't know, probably not the case in Poland, but one of the potential side effects is increased pressure of the spinal fluid inside the head. Rare, but not without risk. So again, risk-benefit analysis. There's not a straightforward answer to that. It could be considered, and if it's offered, you would want to monitor for you'd want someone prescribing it who has experience. It's typically going to be an endocrinologist. And then monitoring for any of those side effects and frankly lack of efficacy, because if you're not seeing an increase in growth, then there may not be any reason to stay on that hormone. I don't know, Kathy, do you have some other thoughts?
Yeah, another direction to go, Danielle, rather than growth hormone would be an evaluation of puberty. As Eddie said, steroids can delay puberty, and puberty also will help with vertical growth. It may be a better idea to evaluate this child or keep an eye on him and see whether or not testosterone might be a benefit for him. That also would help with vertical growth. It may be more beneficial than growth hormone.
Great, thanks, guys. All right, one of the last questions we have, I wanted to get a clarification on recommending dosing for deflazacort. Right now, we are giving it 5 days a week, but I've been recommended 7 days by our endo. Our neurologist wants us to stay on 5. My question is, with adrenal compromise, is it better to be on 7 days?
I don't know that 5 or 7 would have any impact on adrenal insufficiency. So my assumption would be that if you're on deflazacort 5 days a week, that you're most likely adrenally insufficient, which is completely normal on steroids and doesn't need any treatment whatsoever. So I've had a lot of patients say, they tested me and found me to be adrenally insufficient. And you're on steroids, so you should be adrenally insufficient. But I don't think 5 or 7 days would make any difference. Eddie, do you have any thoughts?
No, I mean, it just gets to the point of all the different regimens that are out there. And I haven't heard of 5 days on, 2 days off. I've heard of weekends on, high doses, and 5 days off. So I'm not familiar with that approach, but it's always an attempt to try to mitigate some of the bad side effects without decreasing the benefit, and so that's just one other attempt to do that. So yes, I would assume that your child is adrenally insufficient. You should follow all the same preventive recommendations that Kathy mentioned and that Brian helped put together.
Awesome. Okay. Another question we have is, I'm looking to enroll my child into a clinical trial, but steroids is recommended. What is the lowest dose that I could put my child on to participate in this study?
This is unlike the Vamoralone trials, which required the boys to be steroid naive. Most every Duchenne interventional trial looking at examining some kind of investigational drug is going to have some kind of requirement for steroid, that the boy come into the study on a stable dose of some steroid regimen. And that's just going to vary from study to study. The one that's coming up more, the question that comes up a lot now is relevant to the gene therapy studies, and both Pfizer and Sarepta, I'm not sure about Solid, but both Pfizer and Sarepta now are requiring that the boys be on a stable daily stable daily dose of either prednisone or deflazacort for at least 3 months before they could potentially screen for one of those studies. But it's going to vary from study to study. There's some, and it's going to depend on the age group. There's some wiggle room in terms of what that dose needs to be. What I've seen is they've generally come down. So instead of 0.75, they might say a minimum of 0.5 milligrams per kilogram per day of prednisone, or a minimum of 0.7 milligrams per kilogram per day of deflazacort. But for those studies in particular, they're requiring a stable daily dose of steroids.
All right. And kind of one of the last ones we'll wrap up here is my son is currently 23 years old. We are looking to wean him off steroids. What is the best recommendation moving forward?
So the recommendation for decreasing and removing steroids is in the protocol. So I would pull up the PJ Nickloff steroid protocol, and I would use that withdrawal recommendation or recipe that's on that protocol. But definitely do not do it quickly, and don't do it without your neuromuscular provider's assistance.
All right. Well, thanks, guys.
And also, Danielle, the only other thing I wanted to say is just because you go off steroids it does not mean that your adrenal glands have kicked right back on. So assume that you will continue to be adrenally insufficient until you have a lab test that tells you that you're not. Sorry.
No, that was a great point. I'm glad you made it. All right, well, guys, thanks again for attending this webinar with us today. I think this is a really great webinar and really informative. Again, these are recorded and available online, and there's also a ton of free resources. As Kathy was saying, please utilize the PPMD app, the PJ's protocols cards and the wheelchair cards. Jet Foundation as well will be handing those out throughout our Camp Promise program and our workshops. Hopefully we'll be in person soon, but again, email us and let us know, and we're happy to ship those free to any families that would like one. We really appreciate, again, our speakers who presented today, Eddie, Kathy, and Brian. Thank you all so much, and for sharing your stories with us as well. If anyone has any more questions, please email us at Jet Foundation, and we're happy to forward those over to the presenters and get that back to you. But with that being said, thanks again, guys, and I really appreciate hosting this with all of you today. I'll let everyone go, and have a great day.
Thank you.
Thanks, Danielle.
Thank you. Bye-bye.
Bye.